has this little pigtail here. So basically, if you look at this, it's kind of like your idea of a straw. So when you're talking like a Levine tube, it's just like a straw. So you put suction on, it just keeps sucking, sucking, sucking. So if you put your finger on the end of the straw, what starts to happen? It starts to pull the tissue up, right? So that would be like a Levine tube. That's what that does. That's why we don't use them very often, because what do you think it's doing to the lining of your stomach if you're using that? Well, it's sucking it up. Yeah, basically. It's just like having your finger at the end of the straw. So if it's hitting the lining of the stomach, that's what it does to it. So they have a Salem sump. The Salem sump is kind of like a straw with a hole in it. So when you have a straw that has a hole in it, and you try to suck on your finger, there's not as much pressure. It's still, you feel a little bit of suction, but there's not as much pressure. So that's basically what this is. This is the vent. You don't put anything in there except this. And the reason you can put this in there is, you see what there's on this side? Little holes. But you don't want to put it the other way, because on this side, no little holes. So then, and if you clog this up, then what are you turning this tube into? A Levine tube. So be aware of that. You never want to put anything and still nothing into this. Do you think it leaks sometimes? Yes. So you want to kind of try to keep it up this way, because if you have it in this position, things are going to start to leak through. And even if it has this, because there's still holes in it, this kind of helps it not leak as much, but it's liquid, gastric fluid. So if it's hanging like this will start to leak too. But it just helps a little bit. And this is nice too, because if you have to get them to the bathroom, because most of these people are fine. Something's just going on with their stomach. They had, some kind of surgery, something's going on. So if they have to go to the bathroom or get up, you can actually use that to clamp yours. So you can put the little way, so you have it like that. If they're getting up and you have to disconnect them from the suction, you can actually do that. And then go to the bathroom, and then when they come back, you would hook them back up. So it's nice to have one of these. This doesn't come in your set, so you have to actually grab this from somewhere on your cart at the NURSI station. You have to grab these. And I don't know what they're called. I was like, to the lab people, I'm like, I don't know, the little cork thing you put on there. Usually the little bucket that I just grabbed. I'm like, I don't know because I was asking them to order some more because we actually don't have any of them. But they're very convenient. You'll see them used a lot in practice. Like I said, they can be used to clock up the end of that. But they should only go blue to blue. And then the white end you can use to cork that up. But when you're putting it in, you always put the blue to blue, never the other way around. So that's your tube. It's not sterile. So, we want to keep it clean, but it's not sterile. So you don't have to worry about it being sterile. You want to put a pad on your patient? Why?
When you start sticking it down, they're going to start dripping and...
Dripping or?
Well, yeah, anything.
Coughing or?
All of the above.
Vomiting. Yeah, they're already not feeling good and you're sticking something down their nose into the back of their throat. So chances are they might start to vomit again. So, which is, something, in most cases I usually get the bucket, and I actually usually put a washcloth in the bucket, because if they start really vomiting, it splashes, and guess who's standing next to them? So if you actually put like a washcloth in the bottom or some paper towels or something at the bottom of the bucket, it helps like absorb and not splash as much too. And I usually will get the whole big basin, because if they're sick that much, this is like trying to catch them. That's a nice big basin. You can just kind of sit it right in front of them, and if you have to, you just grab it, put it close to their face.
Maybe toilet paper, because then you can just flush it all.
You could, yeah, you could. Yeah.
There you go.
Yeah, but I mean, usually at this point they've kind of, it's not a huge amount. They vomited, a whole lot. It's more of just bile. They just keep throwing up bile at this point. Because like I said, it's not the first time you throw up. You're gonna call the doctor and be like, let's put in an NG. This is like the extreme. So this is somebody that's been sick for some time. You give them Zofran, nothing seems to be helping. You suspect there's something going on in their bowels, and that's why they keep throwing up. So the first time they throw up, we're not gonna be like, let's put in an NG, because it's not very fun. We're not gonna put them through that for that. So this is somebody that's usually been feeling kind of yucky for a while. And like I said, or they come with it after surgery and it's been pulled, and you got to assess your patient. If you still feel they need it, then you would have to put it back in. All right, so you want to have gloves on. You want to wash your hands and have gloves on, of course, because like I said, they may be in contact with body fluids. You want to make sure that your suction and everything is set up properly. You have your tube here. You want to turn it on. What do we want to put it to? Intermittent and low. Unless otherwise asked, low intermittent suction is where you always want to set it. Because anything more is really irritating to the lining of the stomach, and so we don't do that. Unless you're trying to like suck a lot out, like an emergency situation fast, you're never going to really do it. And the same thing goes with a Levine tube. You're never going to really ever see Levine unless for some reason you have an emergency situation, you want to get stuff out quick. In most cases, you're usually going to see your Salem sumps, because the other, having it on a higher suction or having it on a tube that's not a Salem sump is really not good for your your gastric lining, so usually you don't see that. So unless the doctor orders it, otherwise you assume that it's low intermittent suctioning. Sometimes they'll have it on high, but as you the nurse, if it's been going for a long time on high, do you think that's something you might want to contact the doctor for?
Yeah.
Yeah. Usually want to give them a call and say, hey, we've had them on high suctioning for a while now, and we're not getting too much out. Do we really want to be doing that? Because again, even though it is a Salem sum, if you have it on high for a long period of time, you're going to start to cause some damage too. So we really don't want to do that. You're going to assess their nose. If you see anything in your nose, any kind of thing that would be disturbed by a tube, so a polyp, anything kind of growth, anything, then you probably want to choose the other end, because it's already irritating to the nose. If they have any kind of growth in there, you're going to cause even more irritation to it. So you probably want to go to the other side to put the tube in. But you don't want, if it's severely enough blocked, then we don't want to put the tube on the other side, because where are they going to breathe? so you want to just make sure you do a good assessment of, are they going to still be able to breathe on the other side? Because if we're blocking both sides, then they're going to have a hard time breathing. But you don't want to irritate anything. You want to sit them up, because they're always at risk for aspiration. As they vomit, and if we're messing with them, they can aspirate that vomit. Or they can aspirate while we're putting in the tube. So you want to sit them up nice and high. And I think anything else that I'm forgetting? Oh, you want to get your tape ready. That's actually nice to do before you put your gloves on. This sticks to your gloves. A lot of places now have kind of like a little Band-Aid that holds the NG tube. If they don't have those, then you can always use old-fashioned tape. It has like a little Band-Aid that has two little things sticking out of it. But you can make that with tape. So what you do is you take a piece of tape and then you split it, but not all the way down, because this is what's going to be on the nose, and then these are going to be wrapped around the tube. All right. So I've assessed. I've set my patient up. If you're right-handed, you want to be on the right of the patient. If you're left-handed, you want to be on the left. Because again, this is not the most comfortable way to be putting in a tube, so you want to make sure you're manually easier for you to put it in. So once you have all that, you want to also have some lubricant, because we're going to try to make this as easy as possible to get down. So you can put a little bit of lubricant on the end, so you just get some lubricant from the nurse's station. They're usually like little packages. You can just stick the end right into the package. For us, we use our mannequin lube, which is really yucky and gross, so won't get your hands feeling all nasty. Well, actually, let me measure it first. So one piece of tape is going to use to mark it. You can also use marker. In the lab, we don't use marker because we reuse the tubes, so we don't use marker. But on a real patient, I actually like to use the marker, because if it starts to migrate out for some reason, you'll start to see the marker work its way out this way. So that means that the tubes moved where you originally had it in. So I actually like to use a Sharpie and mark it, but for here we use tape because we reuse these tubes. So we're going to measure from here to here to the xiphoid process, and then you're going to mark your tube. And that's just going to tell me how far I need to put my tube in. And now I've done that, I'm going to lubricate it. Alright, so my tube is nice and lubricated. So, I'm forgetting anything else. So, as I put this in, it's nice to have your partner here holding a cup of water. Partner, can you hold my water? With straw. So, is it the end of the world if I give this patient water? No, we're going to suck it right back out in a minute. The only reason that I would be concerned is if this patient had any kind of aspiration precautions. So if this is like someone who's had a stroke and is intolerant of it. But if they're NPO just because they've been throwing up, if you give them a little bit of water, it's not the end of the world, and it just feels more natural. So as you have them gulp water, it feels more natural. It's easier for them to do this. And they say, pretend and swallow. Yeah, pretend and swallow, and they're going, they're not getting anywhere. Versus if you give them a cup of water and you have them naturally swallow, it's their natural swallow. So as they swallow, you advance the tube, and it's much more natural way. Versus in saying to swallow air, and now they're all nervous, and you're coming at them with this tube, and they're just going to scrunch up their face and try to swallow, and they're not going to be able to. So it works well, unless they're a precaution that you can't give them thin fluids, then you would be concerned. But otherwise, you're okay in having them just give them a little bit of water, and you'll see most nurses do it that way. So basically what you want to do is you want to start pushing it back. So when you start to bring it back, you're going to push your head against the pillow, and you're going to kind of start to feel almost like a little resistance. When you feel a little resistance, that's when you want them to start tucking their head in and start swallowing, because that's where you kind of want them to start swallowing the tube. If they start coughing, where did I get the tube? Yeah, it's in their airway. So if I start swallowing, it's in their airway. So then I want to pull it back. And do I want to pull the tube back all the way out? No, don't do it. Just leave the tube. You've gotten it advanced that far at least. Bring it back, give them a break, and then you try again. So never pull the tube completely out. It's not a sterile procedure again. We put stuff in our mouth. It's not sterile. This is not a sterile procedure. It's going down into their stomach. Your stomach's not sterile. So you just kind of back it up and give them a break. If they start gagging, what do you think's happening to the tube? Yeah, and it's usually what usually causes that to happen.
Is that when it's coiled up?
So that's another thing. If they're like, then it's coiling up. It's not going down, you know, and you'll start to see it. And when you look in their mouth, oh, lo and behold, you'll see a nice little coil developing in the back of their throat. So again, you pull back, give them a little break, because now they're going to feel like hell. I'll give them a little break, and then, you know, give them some water again and have them swallow. Yeah, it's not fun. It's really not. You feel like you're the worst person in the world, like you're torturing. But once you get it in and you give them a little bit of a break, and the suction goes on, you know, x-ray comes back, they usually start to feel much better, because now they're not feeling like they have to throw up all the time. So they do start to feel better. But while you're doing this process and they're already feeling so awful, they just hate you. And you know they hate you, and all you can say is, it's gonna make you feel better. Just bear with me, Mr. Jones. This will make you feel better, you know. But they usually don't believe you, and sometimes they won't let you put it in, you know. But I usually try to convince them. I say, you know, just give it some time. Let's put it to working, and I bet you're going to feel better, because then you're not going to feel like throwing up all the time, which, you know, when you feel like vomiting all the time, you just feel, I mean, you guys have had the flu, when you're just like that constant throwing up, I mean, it's that times 10, people just feel like they're just dying, you know, if your bowels are not moving, everything's coming back, so they just feel like not good. So if you get this in, it does give them relief, at least until we figure out exactly what's going on. And sometimes they may have it in for a while. If those bowels don't wake up, or that obstruction continues, or the inflammation's still there, they may have the NG tube in for a while. So, but most cases, once it's over the initial period, they appreciate that they're not constantly vomiting, and they start to feel a little bit better. So, but yes, this is not the patient's not too excited about this. So you're going to have them push their head back. You're going to look in with your light, and you're going to start putting it into your mannequin. Then you're going to, like I said, just kind of start to see it come down, and you also start to feel a resistance. Then what you want them to do is bring their head forward, and you push the tube in, and you push it in. Yep, and usually it's not that hard on a real person. Though it is sometimes, because it coils, you know, that's probably the most common thing. It starts to coil, and so as it coils, and you're like, oh, then you gotta pull back, give them a little break, and then you do it again. And then you kind of do that process until they're able to swallow down the tube. And then when they're forward, that's when you have your patient, you know, as you're instilling swallow, 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 because you want them to naturally be swallowing as you're putting that down there. So if I think I got it in, I'm going to tape it at this point, because it's a mucous membrane. And if you let go of this, guess what happens?
Push you down.
Yes, it comes right back out. And this is the heavier end, so it just comes right back out. So I know the book and everything says, oh, wait till you know correct placement to tape it. Tape it. The worst thing you have to do is untape it. Not the end of the world. Versus having to go through that process with your patient again, and now they're ready to kill you. So just, you know, I just tape it. If I think I got it, I tape it. And I secure it to make sure that it's not going to go anywhere. And like I said, the worst that can happen is I have to untape it. And then you want to put the flat end on the nose, and then you just kind of wrap these around. Wrap them around. And the Band-Aids, the new Band-Aids that come, they're the same thing. They got a flat end and two little things that wrap around. So you're going to put the flat end of the Band-Aid on the nose, and the two little parts that stick out get wrapped around. So it still works the same way. So either way, you have to secure it, get that nice and secured on. So my tube is secured. So now I'm going to make sure it's really where it's supposed to be. In a real life, and then you want to make sure you have this corked too, because if I had it open like that, what do you think is going to happen? It's going to start to leak out. So you want to make sure you have this closed if you're not messing with it. In a real life situation, usually they're going to always send them for x-ray for the initial placement. We always want to make sure, because these are, you know, the pH is pretty effective, but in real life situation, we want to make sure. So in the initial, we're going to always make sure that it's where it's supposed to be. An x-ray, they'll usually get a standard x-ray. Sometimes they come in and do it at the bedside if the patient can't even go down. And then they'll call you right away and say, it's where it needs to be. And then you're okay to use it. But you think we're going to x-ray them every time we're going to put something in there? No, they would glow. You know, you would be exposing them to way too much radiation. You can't expose them to that much. So that's when you're using these other measures. You're using auscultation or using the pH to find out if it's where it should be before you flush it. Usually you flush this every 8 hours. Just to make sure we keep it patent, because again, those things can get dry and kind of crusty in there. So if you're not flushing it out and keeping it patent, it can clog up. So we want, usually most places, every 8 hours, you're gonna check for placement and you're gonna flush it. It's usually policy. Auscultation, research has shown, is not the best way to check this, but you will see in many places it's still the policy. So if it's still the policy where you work, then you're covered by the policy, though it's not the best way. And you will find that many things take about 10 years to go from research to practice. So though we know that's the best way now, it will as you guys practice, you'll start to see that pH is going to be checked more and more. But right now, it's not done across the board. So if you're where you work, the policy still says that it's okay to auscultate for placement, then that's acceptable to do. Though we know that's not the best way, that nurses sometimes mishear things and it's not your most effective way. But you're not going to check it that way as your first time. That's usually when you're going to flush and things like that. The first time I would, everywhere I've ever worked, you always send it to x-ray. You want to make sure it's where it should be initially. And then you want to check for placement anytime you put anything in there. So if you're going to put anything in there, you need to check for placement. And a lot of policies usually say that's part of your assessment for NG. So you have your patient, when you're checking your NG, you're going to check for placement and you're going to flush every 8 hours. Everywhere I've worked.